Okay, ma'am. You can check out, ma'am.
Yeah. Just give me a moment.
Ma'am?
Yes, can I share the screen
Okay.
now?
Yes, ma'am. Shall we allow participants, ma'am?
Yes, ma'am, definitely.
Ma'am, there will be an introduction session, ma'am.
Yes. I will keep the screen ready.
Okay, ma'am. Good evening, everyone. Quoting Nelson Mandela, the greatest glory in living lies not in never falling, but in rising every time we fall. With great joy and immense pleasure, I extend my warm welcome to all dignitaries, guests, and delegates present here for Dr. Sudiraj N. Memorial Free Webinar Series organized by DIKSHA Academy in association with Ayurveda College Coimbatore under the banner of Azadi Ka Amrit Mahotsav. In today's session, we will be discussing about routine knee injuries by Dr. Dipti Godbole, ma'am. Before starting the session, I would like to go through few of the basic instructions to be followed throughout the session. For uninterrupted class session, use laptop with high-speed internet connection. Please make sure your microphone is on mute to have a disturbance-free session. In case of any disruption, please check your internet connection firstly, and if the problem is within our network connection, kindly raise the issue in the chat box. Filling your full name to be displayed is appreciated. Any questions can be raised, posted in the chat box. Questions raised will be cleared at the end of the session. Next, I would like to invite Dr. Needu Case Ma'am, Assistant Professor, Department of Chikiৎসা, Ayurveda College, Coimbatore, to deliver the welcome address.
Thank you, Sri Lakshmi. So, good evening, one and all. It's my privilege to extend a cheerful welcome to you all. As you all know, today's session is on the topic routine knee injury by Dr. Dipti G. Godbole, who is an associate professor, Department of Rachana Sharira, Esteem Institutes of Ayurveda and Hospital, Bangalore. I extend a warm word of welcome to you, madam, for accepting our invitation and for being with us here today.
Thank
Hope
you.
your valuable experience and views on this area will be enlightening to all of us. And on behalf of Ayurveda College, I once again welcome you, ma'am, and all the delegates to today's session. Thank you. Thanks so much.
Thank you, ma'am. It's a great pleasure for me to introduce our guest speaker, Dr. Dipti G. Godbole, ma'am. Dr. Dipti G. Godbole, ma'am, completed her UG and PG from Ashwini Ayurvedic Medical College, Devangere. Currently, she is working as Associate Professor, Department of Rachana Sharira, SDM Institute of Ayurveda and Hospital, Bangalore. Ma'am has over 7.2 years of experience in teaching and taking general yoga, yoga therapy for specific ailments, and also Garbha Yoga. Published an article on the topic entitled A Variation in the Formation of Portal Vein in International Ayurvedic Medical Journal in December 2018. We are extremely obliged to have you here, ma'am. Now, without any further ado, let me hand over the session to Dr. Dipti G. Godbole ma'am to enlighten the mind with her knowledge. Over to you.
Yeah. Thank you, ma'am. So without taking much time, let me start with my session, today's session, that is routine knee injuries. So looks to be, it's audible, right, ma'am? There is no disturbance in between, right?
No, ma'am, it's audible.
Okay, ma'am. Yes. So I have chosen a very common topic, yet very important one. So that is routine knee injuries. So on our day-to-day basis, when we sit in OPD, what are the regular knee complaints that we receive from the patients? So on a routine basis, on a classical OPD basis, what are the routine injuries we receive? So that is what I want to discuss and highlight in today's session. So let's quickly go through this. So before we actually go into this routine knee injuries topic as such, let us first, I just want you to summarize briefly about the anatomy of the knee joint, which is very much needed to understand the routine knee injuries. So you are all familiar with, I won't be going in detail about that. So just a brush up for you about the anatomy of the knee joint. So as you know, this is a synovial joint of hinge variety. So synovial joint basically, and among that subtype it is hinge variety. So basically it is formed by the femoral condyles and the tibial condyles. Hello?
Excuse me, ma'am. Ma'am,
Yes.
the PPT is not visible, ma'am.
Is it?
Yeah, ma'am.
I shared it. Just a minute.
Okay, ma'am.
Is it visible now?
Yes, ma'am.
It's visible?
Yes, ma'am.
Yeah. Okay. So this is again a synovial joint of the hinge variety, belonging to the hinge variety, and it is made up of, it's a complex joint because it becomes a joint only when it's formed by two or more than two bones. So those bones are mainly from the femur, tibia, and the patella bones. So convex surface of femoral condyles and concave surface of tibial condyles will form a complex joint known as knee joint. So this is the joint which connects or joins the thigh bone to the shin bone. And other than that, we get the attachment of many tendons and ligaments in this knee joint. So you can see in this picture now, very clear picture. So you can see the femoral condyles here. Above you can see the femoral condyles, and below you can see the tibial condyles. Okay, there is patella intervening, so that we call it as a complex joint. And other than that, we have a lot of ligaments here, attachment of many ligaments here. And then we have tendons from above known as quadriceps tendon, which is inserted onto the patellar surface here. So let us just brush up those things. And see this, these are the basic ligaments that you must know. So we have medial and lateral collateral ligaments. We have menisci, two menisci, medial and lateral menisci. Then other than that, we have cruciate ligaments. We have anterior cruciate ligament from front and posterior cruciate ligament from behind. And apart from this, we have quadriceps tendon, patellar tendon, quadriceps tendon from above, patellar tendon from below. So these things you will find when we see the knee joint from the front view or from the anterior view. Now, when you see the right side diagram, here there is a word known as tibial plateau. So this tibial plateau will describe, that means there is nothing to get confused. It is nothing but basically the tibial condyles, which are concave and which are there in the upper surface. That itself is designated by another term known as tibial plateau. And there are some more landmarks here, tibial tuberosity. Specifically, I am showing you these landmarks so that when we discuss about the knee injuries, you have to be thorough with these landmarks. So after that, we have quadriceps tendon. In this diagram, you can clearly see the quadriceps tendon. From below, you can see the patellar tendon, which is coming down. Other than that, we have a very clear view of the lateral meniscus and the medial meniscus. And when you see from the posterior, till now, whatever diagrams you have seen, it was from the anterior view. This posterior view will help you to understand what other structures are there from the posterior. So cruciate ligaments also you can view clearly from the posterior view. Other than that, again, menisci posterior surfaces as visualized clearly. Other than that, you can see the gastrocnemius muscle and the medial head and lateral head of the gastrocnemius muscle. Please see those which are there on the either sides. So these things are needed again when you to understand the routine injuries in detail. And then on the other hand, if you see, again, we have in different colors naming the ligaments, menisci, and lateral collateral. So in general, what I want to say is, from the anterior perspective as well as from the posterior perspective, both the ligaments, means all the ligaments, whichever are listed in the diagram, can be visualized very clearly. So both from both the views. Other than this, very basic things you have to know is, so see, this is it may look small, but still it is important to know. So see the bone, see the attachment of muscle. So see the part which is called as the joint head. See the capsule. Capsule is the outer fibrous covering of the joint, that is called joint capsule. Other than that, I showed you the tibial plateau, so that we can take it as the socket of the joint or the joint socket. Then below here, there is marking of tendon. That tendon is the marking of hamstring muscles which are coming from behind and forming the tendons there. Other than that, there is below again bone, that is tibia bone. Articular cartilages are there which are marked in white color, so that they help in holding these ligaments in anatomical position. Other than that, you have a synovial membrane for having the lubrication for the smooth functioning of the joint. Other than that, we have joint cavity, the space in between the joints, we call it as the joint cavity, and which has good amount of synovial fluid, so that it will be avoiding the friction between the joints. And please, and on the left side, if you see the this one diagram, again we have blue markings which are important to be known as bursa. So bursa is basically a fluid-filled area in this joint area, so which will help in reducing the friction and rubbing of the joints in between. So majorly you have to know the names as Supra Patellar Bursa, which is marked there above. Supra means above the level of patella. Infra is below the level of patella. So both sides we have Patellar Bursa. And before the beginning of patella, we have a covering by name known as pre-patellar bursa. So bursa is also important to know the routine knee injuries. So these are the basic things that I wanted to highlight. So just summarizing once again, type is synovial, plain joint it is. So the joints that it forms is tibiofemoral joint, patellofemoral joint. So with these names, you can understand that it is a complex variety of the joint. And then, as I said, there are so many ligaments. So these ligaments are basically divided as extracapsular and intracapsular. Extracapsular means those ligaments which are attached outside the knee. So for example, patellar ligament is attached from outside. Medial and lateral patellar retinacula, they are attached from outside. Medial collateral ligament, lateral collateral ligament, they are also attached from outside the knee. So these set of ligaments come under the heading of extracapsular. So intracapsular means those which are attached within the capsule of the knee joint. So for example, cruciate ligaments. Just now I showed you the diagram here. So cruciate ligaments. So if you see the location of these cruciate ligaments, exactly they are intracapsular. They are lying within the capsule of the knee joint. So they are designated as intracapsular. Other than that, we have medial meniscus and lateral meniscus. So here again, I'll show you, take you back to the diagram. So you see here in the diagram, medial meniscus, left side diagram, you see lateral meniscus, medial meniscus, they are again intracapsular because they are very much within the knee joint capsule. So that is how is the designation extracapsular and intracapsular. Then after that, we have the movements. Blood supply innervation is not important for today's session. So movements, you have to know basically two movements are possible, only flexion and extension. So extended movements are in the form of medial rotation and lateral rotation. So this you are familiar with what it is. So after this, whatever I explained you in the diagram, showing the diagram, the same I have written in this slides here. Bursa is basically the fluid filled pouches which are known as bursa. So they're required to reduce the friction within the knee joint. Okay. So same things I have written in this. So now directly let us go to the topic after knowing this brief anatomy of the knee joint. So there are general principles which are coming under the section of the knee ligament injuries. So what are the general principles? In the general principles, let us see stepwise, like what are the causes, what are the causes for injury, routine knee injuries, what are the general principle lines of treatment, and so on things. So for example, let us start with the causes or the etiological factors. So it is common in athletes. It is means here you have to take the overall knee ligament injuries, whatever the routine knee injuries are there. So they are very much common, or the common causes in the athletes. Athletes are the one who are prone to this knee ligament injuries. So in the athletes, again, we have two sections, contact sports and non-contact sports. So non-contact sports, we can take like cricket, table tennis, badminton, or your diving, swimming, all these things. So where there is no much of impact to the body of a person. So that we take it as non-contact. Rest all of your other regular sports, they come in contact sports. So in both the varieties, in both contact and non-contact sports, we can have the people prone for this knee injuries. Other than that, it could also be due to some trauma, direct trauma, due to the collision with so two opposing athletes when they're facing each other. If there is a collision between them, then also there can be a pathology of the knee there. So it could be direct or it could be indirect also, because of the rotation and any twisting kind of force. If it is there, then that can also cause the knee injuries. Other than that, when a person meets with a road traffic accident, so that is a direct trauma once again. And very commonly these knee injuries are going to happen because of the dashboard injuries. So dashboard injuries, when you are driving a car, dashboard, directly you hit on the dashboard, there is definitely a direct injury to the knee. So one of the very common causes for the knee injuries. Other than that, if one person is falling from a height with twisted forces, obviously when he falls from a height, definitely there is a twisting of the ligaments or twisting of other structures of the knee joint, which will cause him the injuries there. Other than that, we have something known as direct valgus force. So two things, one is direct valgus force, another is direct varus force. So I'll just show you the diagram of that. What is that? So now please see the diagram here, which is at the lower section, normal varus vagus. So varus here is, so when the knees are apart, so in the diagram when you see the knees are apart, there's a gap in between. So that force, when we apply from outside, there is a gap. When it creates a gap, we call it as the varus force. And see the contrast of that, that is valgus force. So knees are glued together, means they are seen inward, facing towards each other. So when they're glued together, they look like knees have been locked together, knock knees. So that is what we call it as valgus. So you have to know the difference between the valgus and the varus forces here. So this is also one of the common. So exposure to the damage from the blow to the outside of the knee. So whenever there is a blow or a hit to the outside of the knee or from the outside of part of the knee, then that force we call it as the valgus force. So when it is from the inside part of the knee, then we call it as the varus force. So this difference you have to know, because some valgus forces will lead to some cruciate injuries, some varus forces will lead to other ligament injuries. So this is the general concept of what is valgus and varus here. Okay, then apart from this, we have something known as unhappy triad. So Donegal's unhappy triad. Donegal is the name of the person who first enumerated this unhappy triad. So what is this unhappy triad? So there are three structures in this. So medial MCL is medial collateral ligament, ACL is anterior cruciate ligament, and medial meniscus injury. So if there is an injury to all these three structures, then we call it as the terrible triad or the unhappy triad, because there is excruciating pain when these three structures are injured together. There is excruciating pain, there is hemiarthrosis, and there is too much of swelling. There is a lot of restricted movement in the person. So that is where we call it, that is why it is labeled as unhappy triad. The person hardly can do any movements there, either on sitting or with support, etc. things. So that becomes unhappy triad. Triad means three structures. So one is medial collateral ligament, another is anterior cruciate ligament, another is medial meniscus injuries. When they are affected together. So I can also show that in the diagram here. So see this left side diagram, unhappy triad. So medial collateral ligament is visualized. It is torn there, red color. Medial meniscus is also torn. And then ACL is also torn there, ACL or PCL. So ACL is torn clearly. So these three together, we call it as unhappy triad. So this can also become this can also happen with the knee injuries because of these etiological factors also. Apart from that, hyperextension. When you're hyperextending your knee joint, then also there can be the injury of cruciate ligaments. So apart from that, I told you like dashboard injuries can also call the injuries to the cruciate ligaments. So next, so we are dealing with the general principles. These are the general causes or general etiological causes or the factors. So general lines of treatment or the goal of treatment here in our knee injuries are the restoration of the anatomy and stability to normal or near to normal. So what happens, either there is ligamental tear, wear and tear mechanism may be there because of degeneration, or there may be trauma because of which there may be tear, or sometimes there may be formation of the blood clot, sometimes there may be the collection of fluid, excess fluid. So any of these injuries are going to happen, then our aim is to restore these function. So to restore these function, either we have to repair them, reduce them, or in some things we are also going to have like a RICE concept. So I'll come to that point a little later. So in general, we have to restore the anatomy of that particular knee joint, because until and unless we stabilize the anatomy, so we cannot repair the structures correctly. So we have to stabilize, restore the anatomy. Once the anatomical structures are restored well, then automatically there is good amount of joint stability. You can move the joint like flexion, extension, hyperextension. So whatever are the normal movements, medial and lateral rotations, so all that will be set back normally. So this is our principle, general principle of the treatment principle, lines of treatment. Now, after this, let us start one by one. Let us see in detail about each ligament injury. So to begin with, let us start with the collateral ligament injury. So collateral ligament injury again is a broad heading. So this includes again medial collateral ligament and lateral collateral ligament, or other words we can also call it as medial, means it has to be tibial collateral, because the medial side bone that we get is tibia, and lateral collateral ligament has to go in reference to the fibular collateral ligament, because fibula is the bone which is on the lateral side. So it is self-explanatory. So again, what are the causes for this? Why this can happen? So collateral injuries are common because of again direct or indirect forces. What kind of forces? Again, Valgus force, the Valgus force or the varus force. So direct injury, or there can be indirect injury because of direct or indirect violence. That is one thing. And commonly this is caused due to the valgus stress. Just now I told you the difference between valgus and vagus. So medial collateral ligament is basically injured because of the valgus force. Okay, because when there is a blow from the outside of the knee, or when you're striking, or when there is a trauma or hit to the lateral aspect of the knee from outside, so that is where, or during collision or anything, so obviously there is injury to the, which is the ligament situated opposite to that. So when you're hitting from the lateral aspect, opposite to that you find as medial collateral ligament. So obviously there will be injury to the medial collateral ligament. Similarly, if you're applying the varus force on the medial side, so you're giving a force, or there is injury from outside, so on the medial aspect from outside, so then opposite to that which you will have is lateral collateral ligament. So opposing is lateral collateral ligament, so that will get injured. But what they say basically is, so lateral collateral ligament injury is less common compared to the medial collateral ligament. So understand this very, like it's easy to understand also. Lateral means they're on the extreme sides. So outside, lateral side part of the knee joint, there is lateral collateral ligament. So lateral to that, there is nothing to support that. Whereas in the medial collateral ligament, since it is towards the body, since it is in the inner side of the body, so there is another leg which can actually give you the support and balance your condition there. Okay, whereas on the lateral side, there is no other structure which is going to offer the support for that. For that reason, lateral collateral ligament injury is less common because of the protection offered by the other leg. Okay, so this is where you have to know the difference. Why? And this is, for example, I have shown you like how is in an X-ray avulsion of LCL. LCL is lateral collateral ligament injury. So it is more prone for avulsion fractures. Avulsion word means when a small piece of bone is attached to a tendon or ligament. You can see in that circle, a small chunk of bone or a piece of bone has been attached means to a ligament or a tendon. It is getting pulled away. It is leaving its original anatomical position because of the force. It is getting pulled away. It is kind of seen as if it is pulled away from the normal position or the main part of the bone there. So that is where we use the word as avulsion fractures. So this is one of the most commonest presentation if a lateral collateral ligament is injured. Other than this, we have, like again, we can designate into 3 degrees. Collateral ligament injuries, we can take them as grade 1, grade 2, and grade 3. So in grade 1, usually there will be a very minimum tear. The instability can be there to some extent, means it is manageable. Okay, and there is some amount of swelling and there is no much of instability. That is means to some extent the person can do the movements. Okay, then we call it a second degree when there is too much, when there is one more step of disruption. So when there is little more instability, with support he might be able to walk for a very shorter distance, for example. So if that is the condition, then we can take it as second degree. Similarly, third degree we can take when totally it is disrupted. When the total collateral ligaments are disrupted or torn out or worn out, then totally there is a lack of movement in the person. He finds very difficult to carry out the normal routine movements. So that is when we designate it as third degree, etc. So when we see these degrees of injuries in the collateral ligament, then we also find some clinical features in that. So person will give the history of valgus and external rotation of force. This is what we discussed. So there will be usually 95% of the times the history will be application of valgus force. Okay, other than that, so direct blow on the lower thigh or upper leg. So either on the lower thigh you find the femoral condyles. Upper leg means you find the tibial plateaus or the tibial condyles. So when the direct hit is there on these regions, definitely there is injury to the collateral ligaments. So common sports like football players, it is common. Rugby players also, it is common. So what happens when this is injured? So patient will have severe pain. He will have inflammation with swelling and hemarthrosis. There is collection of blood within this region. So hemarthrosis is one of the very, very common presentation for any of the routine knee injuries. So if it is beyond grade 2 or grade 3, definitely there is hemarthrosis in any of this condition. So when we do the clinical examination, so even he will not allow you to touch the place. So local tenderness is what is that? So that could be at adductor tubercle. Adductor tubercle. So again, now a little bit you have to understand this. Adductor tubercle is one prominence which is situated on the lower extremity of the femur. So just for your sake, I have put this diagram. So see the adductor tubercle, it is on the lower part of the femur at the above the level of the medial condyle. So above the level of medial condyle, you can see this adductor tubercle. So you have to know the location so that you understand the clinical exam, to do the clinical examination there. Okay, so when you do the examination at this point, there is severe tenderness that is felt at the level of adductor tubercle or where there is insertion of the tibial collateral ligament. At that point, there is severe tenderness. Okay, the person cannot do the extensor mechanism very clearly in this. So to do this, we have some clinical tests. So these tests, I have the links, your video links, I'll share with you people. See, these are the links for the tests that we have to do. So clinically, so if I go on showing these things, it will take a lot of time. The time that I have is 1 hour. So I'll share these links with you. So you find some time to see these clinical examinations. Other than that, how do we confirm the diagnosis? For that, we have some investigations known as stress radiographs. So we apply some force, we give some force, and then at some points, we take the pictures, we take the X-ray views in different views. So these will help in knowing you the degree of tear. So what is the degree of tear, whether it is in grade 1, grade 2, grade 3, like that. For that, we do this common routine investigation known as stress radiographs. Other than that, we also send the patients for MRI scanning. So this is one of the very good method, like where we can actually see the MCL tears or ACL tears or meniscal injuries. Everything will be very, very evident at the level of MRI scan. Other than that, we can also do the arthroscopy. Arthroscopy is just like your normal routine endoscopy, what you do. So there is a light, there is a video camera on the other side. So you take that scopy and you have to probe it inside the knee joint. So with that video light on the other side, you can actually see the interior of the knee joint. So what has happened with that? So because of the light, you will be able to see what kind of injury is there. So especially meniscal injury and cruciate ligament injuries can be made very well in this arthroscopic examinations. So these are the routine investigations that we send the person to confirm the diagnosis as well as to rule out the other conditions. So for example, in the treatment, see, this is the gold standard line that you should know. Fresh injury non-operative treatment is the mainstay of the treatment. If it's a fresh injury, and if it is in first grade sprain, second grade sprain, then there is no requirement of the surgery in this case. Okay. Symptomatically, you use this RICE concept. RICE is rest, ice pack, compression, and one more is elevation. So this is the general line of treatment in any of the orthopedic injuries. So just remember this mnemonic as RICE, RICE, RICE. So giving good amount of rest, applying the ice pack, giving the compression, elevating the particular limb. So with this only we can manage the first and second degree sprain. So with this method also, and along with this, we can give anti-inflammatory drugs also. So with this, there will be relief in the pain. Other than this, if this is not going to get managed with this RICE concept or with NSAIDs or even with doing physiotherapy, so then we have to go for the surgical repair. And usually when it comes to the surgery, definitely it will be in the grade 3 or the 3rd degree sprain in that case. Okay, so if they're old tears, already it is chronic, or if it is associated with other injuries, okay, then we have to repair or we have to reconstruct. So some fibers, if they're torn out, we have to bring them together and stitch them. So that is what we call it as a repair. And if it is severely, badly injured, then we have to carry out a major surgery. That is, we call it as the reconstruction surgery as such. Other than that, in the market, you will also get this braces, knee braces. So temporarily in grade 1 and temporarily 3rd sprain, post-operatively, we can use these braces so that it gives a good support and you will not feel that pressure, or you will not feel that swelling or pain to some extent after that. Other than that, these braces also can be used in 1st degree and 2nd degree sprain also. Okay, so what we have to do in the old cases, if the cases are old enough or chronic enough, then we don't have an option. We have to do the reconstruction in these cases, because there will be so many symptoms. There will be stiffness, means the person will have, and that too if it is a degenerative age factor, considering the age factor. So there's no other option other than doing a reconstruction. So you have to know at what degree, what management we have to do. So I just enumerated examples here. I'm not going to details of this. So for example, now we are studying the heading of collateral ligament injuries. So if there is a tibial collateral injury, if the tibial collateral injury is intact in the sense if it is properly there in its original position, but if it is lax, it is there in its proper position, but the laxity is there is a laxity in that, then we have to do the distal transfer. Distal transfer is either a muscle or a tendon or a nerve is taken and it is implanted where there is a damage. So in that place, a new tendon or a new muscle or a new nerve is transferred in that area. So in that case, we have to do this. So for example, if this entire ligament is destroyed, okay, torn out, okay, then definitely we have to go for the reconstruction. If a very small amount of that part is torn, then we can finish it off within repairing it. Repairing, I said, right? If a few fibers are torn out, then we bring them together and we do a sewing there. So that also is good enough. But to torn out completely, then we have to go for the reconstruction. So how do we do the reconstruction? We use the hamstring muscles. So in the hamstring muscle, especially we use this semitendinosus muscle, because this is one muscle which gets inserted at that site, at the level of this TCL, where it is going to get inserted. So that is why usually we take this, we call it a semitendinosus grafting. So for doing the reconstruction. So this much, if you know basic things, it is enough. And for example, if there is an injury to the fibular collateral ligament, so then also we have to, if it is in the proper position, but if it has increased, too much of fibrosis is there, too much of thickness is there, okay, swelling is there, then again our distal transfer is recommended. And as usual, if it is completely restored, again we have to go for reconstruction. But now you will be using the fascia lata and biceps tendon. So you may ask me how to remember these muscles. So for this, really your anatomy has to be really good in these conditions. But in one word, I'll tell you now. So fascia lata is one band of fibers which you basically find it on the extremely on the lateral side. Thing one. Second one is biceps tendon, biceps femoris tendon, which is a part of the hamstring muscles. These tendons are also going to get inserted on the lateral aspect. So that is where we call, because see the heading is lateral collateral ligament. So laterally, whichever are the muscles or whichever are the tendons, that is what we use for the purpose of reconstruction. Similarly, semitendinosus comes on the medial side. So where there is tibia bone. That is why we select that tendon to use for the reconstruction purpose. So like that, you have to know which structures come on medial side and lateral side to understand the structures that they use for the reconstruction. Okay, so with this, we are done with what we call it as the collateral ligament injuries. Next, we will go to the cruciate ligament injuries. So as I said, cruciate ligaments are intracapsular, very much they are there within the capsule of the knee joint. I showed you the diagram previously. So in that cruciate ligament, we have anterior and posterior cruciate ligaments. So what can happen? Injury will happen, but what can be the presenting type of injury in these cruciate ligaments? Definitely it is a tear. So there is a tear. So the tear can be minimum or the tear can be extensive. When it is minimum, then we call it as partial tear. When it is extensive, then we call it as a complete tear. Okay, again, grade 1, grade 2, grade 3, we can differentiate in that way. So of all the knee ligament injuries, ACL tear is the most common. I highlighted the word most there. So in general, in your routine knee injuries, so most commonly that we get on day-to-day basis is ACL tear. So this is one of the most commonest knee ligament injuries that we get. So what may be the cause for this? The cause will be the external rotation with abduction of the flexed knee, hyperextension once again. So if you're doing too much of hyperextension and with internal rotation, then definitely this ligament can get torn away very easily. So that depends once again on whether it's partial or complete. That again depends on the force that is applied. If it is too much of blowout or a force, then it will be complete. If it is a minimum force or if it is due to a slip or a fall, then it will be a partial one. But this is described as a disabling injury because it is anterior, front. The person cannot lean forward. They cannot sit aram se. He cannot bend the knee even to a degree of 45 degrees like that. So it is disabling, and the knee may immediately collapse and is painful. Collapse, and he feels like as if they're locked, they're buckled inside, like my knee will be detached, something like that. He feels to that extent. So what is the incidence of this tear? They say it is 67%. So it is sports related once again, and 67% is the incidence. So that means you can understand how common it is. Okay, higher incidence is once again in the female individuals because household works are done by the females maximum. Okay, mopping, and they sit and they do the work, they do the squatting, they wipe the floor. So whenever they are doing such bending the knee movements, definitely there is a pressure that is created over the ACL ligament there. So, and more upon this, if they are obese, then definitely that is also an added factor for them. So what is the role of your ACL in your knees? It gives AP stability. AP stability is antero-posterior stability. So in order to carry out smooth flexion extension, this is helpful. Other than this, to maintain restore the mechanical function. So then also this is very much helpful, whichever your ACL. So what are how to clinically diagnose that there is a ACL tear? So there is something known as popping sensation. Popping, you might be familiar with this word, popping sound. So sometimes if there is a severe osteoarthritis, grade 3, grade 4 like that, when the person is walking, he himself will feel that crepitus sound in his knees. So similar popping sensation will be heard in the front of the knee when the person is walking like this. So that is what, in other words, we can call it as the popping sensation. The person can feel, and even when we do the clinical tests also, there is a popping sound that is coming up in the knee. Okay, so that is what is we call it as the joint noise also, joint noise. Okay, so that kind of sensation is felt, especially when there is a ACL tear. Other than that, the person can also have this knee give away. Like why they have used this word, he feels as though they are going to come out of his anatomical position. That is one thing. Second thing, he may also feel it is buckled at the time of injury. Buckled in the sense as though it is fixed firmly inside. So where he cannot actually do any kind of movements. When it is buckled, so there is some amount of stiffness, there is a lot of disability at that time. When it is gave away means definitely ACL would be lax at that time. Okay, so these are the very interesting words that are there for seeing the clinical features, and any one of this you see also, you can suspect that there would be a ACL tear. Other than that, our usual swelling will be there. Hemarthrosis, as I said, maximum cases will be having the hemarthrosis, that is collection of the blood within that. So that is also one of the common reasons. So main clinical features I have highlighted, everything I have not, only that which is going to help us in the clinical diagnosis, only those things I have taken. So in the differential diagnosis also, differential diagnosis is little important to know in this, because there are these list of conditions which mimic exactly to that of the ACL tear. So hemarthrosis can be even primary, hemarthrosis can be even secondary. So for that reason, it is given as the first differential diagnosis. Okay, other than that, so many things are written down. So all these can mimic the conditions of the ACL tear. So best part is you remember these clinical features, and 95% you will be easily suspecting whether there is an ACL tear or not. Okay, still for further confirmation, you can do some of these clinical examinations. For example, the best examination is this anterior drawer test and the Latchman test. So I'll show you the diagram here. So anterior drawer, anterior means the shin is to be pulled forwards. I'll just show you the diagram here. I think I have not put the diagram. I have not put the diagram, but I can just briefly tell you about that, how it is done. Only one I can tell you. Other one, if I tell, you can understand the rest of the things. There is no much of difference in that. Anterior drawer test. What we do is we may make the person, we put him, we tell him to lie flat on his back, supine position. He has to lie flat on his back, that is in supine position. Then we bend the knee we flex the knee at 90 degrees. So this much you can understand. We are putting him in supine position, then we are bending the knee at 90 degrees. After doing this much, the examiner or the surgeon has to sit on the side of the leg that is affected. He has to sit on the examination table, and he has to hold his fingers at the level of the tibia bone, at the shin. Shin is tibia bone, and from behind he has to put the fingers from behind, and then he has to pull the shin forward. Shin part has to be pulled forwards. That means you are going to give some force so that you are going to pull the shin forward. Once you pull the shin forward, then if you are feeling that laxity, or if you are feeling that knee give away kind of thing, then we can tell it as the inference as the anterior drawer test is positive. Anterior means the shin will be pulled anteriorly, or it will be pulled forwards. So once you pull forwards, so there is popping sound can be there. Other than that, you can also see some amount of instability in the joint, as though it is going to come out now. So if that is the condition, then the test is positive. Okay, so this is one test. Another test is Lashman's test. This is also one of the important tests that you can confirm the diagnosis of ACL tear. Here we will not be same supine position. So we will bend the knee slightly in the sense maybe 20 to 30 degrees is what we bend the person's knee. We flex the knee. After that, again, he sits on the side of the examination table. Then again, he will stabilize the thigh. So first he will give little rest to the thigh. Later, he will again pull the shin forwards. So once there is pulling of the shin forwards, then there is some amount of shift of the tibia bone little forwards. Okay, so tone allows the shin to shift too far forward. That's what you feel, the tibia is shifting more forward from its anatomical position. So when you see this also, then also we say that the Lachman test is positive. So for all these things, I have shared the video links. You can aram se see them. There are hardly 1 or 2 minutes videos there. So how to perform a test they have given. You can just see those things. Basically, these are the two main tests, clinical tests that we do to confirm the diagnosis that there is an ACL tear. Other than this, these are the complications, normal complications that we come across with the ACL tear. So meniscus can get degenerated, osteoarthritis, we know, we can understand it very easily. Patella can get fractured because it is anterior cruciate ligament. So above that there is patella, so that can get fractured. And just below that level of ACL, we have patella tendon. Okay, ligamentum patellae getting inserted there. So that can also get ruptured sometimes if there is an injury. So these are the main complications that you have to remember. Okay. So these are the other, once again, the links so that you can just see 1 or 2 minutes videos. Okay. So how much will be the disturbance if there is an ACL tear? So there is an ACL tear now. Just imagine there is an ACL tear. There is knee instability. Knee instability means the person cannot do the usual movements, aram say, like how he is doing on his regular basis. Once there is knee instability, repeatedly there is damage to the menisci. See, immediately if you are treating, then he will recover faster. But if he is neglecting, or if he is repeatedly putting more force or walking vigorously, doing vigorous exercises, etc., these things, then definitely day by day, because of increased pressure, there will be damage to the adjacent structures also. For example, there are menisci on the sides. There is articular cartilages are there on this above and below. So these are the structures, adjacent structures, which are there. So because of repeated force on that area, even they can get injured. Okay, secondary OA of the knee. So because if these multiple structures get injured, the person will finally land up in the osteoarthritis, known as secondary osteoarthritis. Okay, so because of a simple ACL tear, person can also go into the stage of the secondary osteoarthritis of the knee. Only when there is repeated instability. That means when there is a repeated force, if it is exerted on the adjacent structures like menisci, articular cartilages, or other ligaments, then the person definitely will have secondary osteoarthritis. So what are the investigations we do in this? We do first is, as usual, taking the X-ray. So you can take our usually any orthopedic cases, we take 2 X-rays. One is in AP view, another is in lateral view. Other than that, we hear some new names, intercondylar notch view and sunrise views. So intercondylar notch view is, so intercondyle means between the 2 condyles. So additionally, we project there is an additional projection of the knee. So we use this for better examination of the tibial plateaus. So intercondyle is between the 2 condyles. So exactly we focus on the tibial plateau. So where there is tibial tuberosity, and other than that, where there are femoral condyles. Okay, so tibial condyles and femoral condyles. In between them, there are intercondylar spaces. So what is there in between these intercondylar spaces? Okay, so we see that if there is any tear or if there is any other problem in these intercondylar spaces, then we want this view of X-ray, which we call it as intercondylar notch view. Other than that, we have sunrise views. So sunrise views, why we call it as sunrise view is because the bone patella, which is there close to this anterior cruciate ligament. So when we take an X-ray in this view, the patella appears to be rising over the horizon. So here what it means is, as though you feel this patella is seen raised from its normal surface. So it is lying on some surface. You feel that is getting elevated from its normal anatomical position. That is where they call it as rising over the horizon. So sunrise, in sunrise view, you say rising over the horizon. So that is where they have given the name it as sunrise views. But this is not done, these things are not done on very routine basis, because if it is grade 3 injury, then the person will have a lot of disability. So then we cannot take the person and go and do the sunrise x-ray, sunrise view x-rays and all, because basically in these views we have to flex the knees. We have to flex the knee and then we have to take the pictures. So if flexing is possible in first and second grade, then we can do this. If it is in third grade, we definitely cannot do this kind of x-ray. But you just, when you read, you will get these terms. Just I'm telling you the what it is. Other than that, we have avulsion fracture of tibial spine. So tibial spine also can come out. I told you avulsion fracture is like a fragment of there is a piece of bone that is getting detached from that main bone. Okay, so like that there can be a detachment from the tibial spine also. So that is where we call it as the avulsion fracture. And the best thing is MRI. Doing an MRI will reveal A to Z about this. Okay, so best thing is doing an MRI. Okay, so that will not have anything like you have to flex the knee, etc. These things. So let it be any straight, any of the stage. Aram se you can do the MRI. So you'll get A to Z the description about the entire thing. Okay, then how are we going to manage this again? So we are going to manage it in a conservative way. When are going without surgery, how do we manage? When do we manage? We manage when it is in grade 1 and grade 2. Conservative, that is avoiding the surgery. Other than that, we are going to use our RICE technique again, rest, ice, compression and elevation. We are going to use that. If that also fails, then we can put long leg casts. So from the upper thigh till the ankle or the foot region, we are going to put a POP cast, or we are going to put the cast, so that the person can do his activities to some extent and there is a good support to his entire knee. Along with that, uniform weight distribution is there. So we can try these methods for 4 to 6 weeks. Post that, we have to take an X-ray and just check if there is if it has resolved or not. So then obviously we give the anti-inflammatory drugs. We also send the persons for physiotherapy. So these are the things that you have to do if the person has been diagnosed with first and second grade of the ACL tear. So other than that, when we do we adopt surgical intervention? We adopt the surgical intervention when there is total tear or complete tear of the ACL here. So completely, if it is torn, then we have to go for the surgical intervention. So so more than doing an open surgery, so arthroscopically assisted ACL reconstruction is best actually, because arthroscopic is also going to serve as a therapeutic tool that will also help you to reduce the pain, that will help you to reduce the swelling, and very clearly you can see the things what is there inside the knee joint, and you can carry out the procedure very well. Other than that, it is minimally invasive. So as a daycare procedure also this can be done. So doing it with the arthroscope, with the help of arthroscope, is having good results than doing it in an open way. So this is what I have told you. So this is how it is. So we do the reconstruction in chronic ACL injury. So if it is an old case, again we have to do the reconstruction there. So again I told you, right, reconstruction means you have to know which structures we are going to pick up. So for example, if we are going to do it with so usually in ACL tears we use quadriceps tendon as a graft, or we use the patellar tendon as the graft. These are the two options, maximum options that we have. Two options we have for choosing as a graft and then fixing it with the reconstruction surgery. So what they do is, I'll just show you in the diagram, semitendinosus tendon, gracilis tendon. So these tendons also can be picked up for doing the reconstruction. So see here, briefly I have shown here. So you see first how there is a tear. see the difference between the tear here. So there is a partial tear, there is a complete tear in the diagrams. Once this test is identified, once this diagnosis is confirmed, then what they do is they will create two tunnels. One tunnel they create in the femoral condyle, femoral tunnel, another they create in the tibia bone, shin part of the tibia bone, that is tibial tunnel. So in between there is a passage, we call it as the graft passage. So in this passage, they take the whatever I mentioned, semitendinosus, or they take this quadriceps tendon, or they take this patellar tendon, and then through the graft passage, so they connect these two things, and then they do the sewing there, so that it sits intact in its original position. Okay, so this is, it's a very huge procedure or a major surgery, but I'm telling it in very short so that basically you understand what is done. So last diagram, what you're saying is, this is how we prepare the graft. BTB graft is what we call bone, tendon, bone, BTB graft. Bone is, so from the quadriceps tendon. So before that, we take a small piece of the patella bone there. After that, we take the quadriceps tendon. Then again, we take the small piece of the shin part of the tibia here. So then we connect the graft. So BTB, it is bone, tendon, bone graft. So when we do create a graft like this, and then we fix it between the tunnels, then the healing process will also be faster, and the person will have a good stability in future after the wound heals post-operatively. So this is the idea behind doing this BTB graft. Okay, so this is how they do it. So in short, I have told you. So because at least these words we read in the textbooks, we should know what it is and what is a graft, which structures they choose for doing a reconstruction procedure at least. Okay, so these are the things that they do. So this is the brief summary of this ACL tear. So this is very common in young active people, usually the athletes. Then it does not tear in isolation. Does not tear in isolation means separately it will not be torn. So usually it will be associated with other ligament injuries. If there is adjacent, so maybe PCL, posterior cruciate, or if the meniscal tear is there. So then as a secondary, we can see this ACL tear also. Other than that, OA changes. OA changes means osteoarthritic changes sometimes also can disturb the ACL. After this, we'll see posterior cruciate ligament tear. This is less common than the ACL tear. So you remember that I had highlighted it as the most common. So this is less common. This can also get ruptured. You can see in the diagram, posterior cruciate ligament, there is a mark which is torn in between. Okay, it is ruptured due to severe rotational injury. So too much of rotation. So too much of rotation, medial or lateral rotation you can have. Then also it ruptures. Dashboard injury, once again, very, very common in PCL tear, or completely if the knee is dislocated. Completely if it is dislocated, then also there can be a PCL tear. Okay, this accounts for 3 to 4% of all the ligament injuries. So now this percentage will tell you how less common it is than the ACL tear. In ACL, you saw it as 67%. So they are contrasting in incidence. What are the clinical features? We see the person has pain, swelling, tenderness over the popliteal fossa. Okay, so back of the knee, we have popliteal fossa. So there will be lot of tenderness when we clinically examine the person in this. So with that, we have to confirm the person, means we can suspect at least he might be having the PCL tear. And clinically, we do the posterior draw test and the posterior sag sign. So this is same as the anterior draw test. But now what we do is, so we apply the force of the shin and we push the shin backwards. So tibia was pulled forwards to confirm the diagnosis for ACL tear. Now the same shin part of the tibia, it will be pulled backwards, posteriorly. So when we do pull it posteriorly, again you can see that laxity or that is coming outside. The person feels like that, and there is too much of pain in that region. So when these things are appreciated, then we can say that the posterior draw test is also positive. So same as that of that. So posterior, because we are testing for PCL. So obviously we have to push the tibia posteriorly to confirm the diagnosis. Okay. So we call it as, see, they are given absence of an end heel and the proximal tibia falls back. That's what, lax. It becomes lax and feel that the proximal part of the tibia is going to fall back. So that we call it as excessive translation. So if that is the condition, definitely we can suspect that there is a PCL tear. So for this also, I have shared the link. Please see this video and then you can understand this test once again. See this diagram I have put again to show you the complete PCL tear. See, there is no connection between the upper aspect and the lower aspect. So much it is torn. Completely it is torn in between. Okay. Okay, investigations, there is no much of difference. Again, you can send for those X-rays. MRI is once again very best in this. Again, management also remains the same. Grade 1, grade 2, you manage how we managed for the ACL. Grade 3, when it comes to complete tore or complete torn stage or grade 3, then we have to again do the reconstruction. So now here we use the medial head of gastrocnemius. If you go back to the second slides, I had shown you there from the posterior view of the knee joint, what structures we see. I had shown you there the medial head of gastrocnemius, isn't it? Posterior view. Now this is PCL tear, posterior cruciate ligament tear. So we have to select the medial head of gastrocnemius tendon to do the reconstruction for this. Okay, so see this, you understand these things. Okay, so here also we are going to do the same procedure. So creating the tunnels and passing the graft passage, but the graft will be by the medial head of gastrocnemius, and then we'll do the screwing above and below, and then we are going to do the sewing from outside. Okay, this is how basically we do the PCL reconstruction. Okay. So for that, other than that, we can also use, so usually we choose this gastrocnemius, this one. Other than that, we can also choose the central part of the patellar tendon, ligamentum patellae I showed you, no? So central part of that small part also can be used for reconstruction. Okay. Other than that, we can use gracilis muscle graft also, gracilis tendon graft also we can use, semitendinosus also you can use. So these are the different examples or structures which you can use. So briefly, I have shown you in the picture. Femoral tunnel is created at the level of femoral condyle here. Here at the tibial level, they construct the tibial tunnel. In between, there is hamstring autograft. So either they would have taken semitendinosus is what they might have taken and created a graft in between to do the proper positioning of the PCL. Okay, so this is all is what about the PCL injury. So combined knee ligament injuries, the word itself will trail. Combine, in combination, if there is an injury, then also there is a lot of problem in this. Okay, so rupture of the cruciate and collateral ligaments. There can be both the cruciate ligament injuries, or there can be both the collateral ligament injuries, or there can be combination of these two, cruciate as well as collateral ligaments. So now you imagine how complex it is. It is rare, but still it is not uncommon. Okay, so this will definitely be very, very disabling condition. Okay, so this kind of injury also can be also can happen. So again, definitely with the word only, you have to tell me like combined knee ligament injuries means there is no other option other than doing the reconstruction. For example, if there is anterolateral instability, anterolaterally, if he is not able to do the movement, then you have to do the reconstruction using the biceps humerus. If there is posterolateral instability, then you have to do the repair again. So whatever may be the combination, end of the day, you are going to do the reconstruction there. If it is in big amount, reconstruction. If it is partial or in small amount, then you can also repair the damaged, torn out structures. Okay. And lastly, we are going to end up with semilunar injuries. I mean, semilunar cartilages of injuries. So semilunar word will tell there are two crescent-like cartilageous structures in the knee joint, which we call them as medial menisci and lateral meniscus. So these two, we also call them as semilunar cartilages of the knee. So this also can occur. So medial meniscus is less mobile, lateral meniscus is more mobile. This you have to know. So why we need these menisci? So they uniformly help in distributing the weight to the entire knee joint. Other than that, they also help in contributing to the knee joint stability in performing the proper movements. So here, which is more commonly injured? Medial meniscus is more commonly injured. To what extent? 71% than the lateral meniscus. These things you have to know. Okay, medial meniscus, because we saw that it is less mobile. That is also the reason. So lateral meniscus, why it is less commonly injured? Because it is smaller in diameter, it is thicker in periphery, it is wider, it is more mobile. So because of these reasons, it has all plus points, isn't it? Smaller and it is less commonly injured. As it is smaller, then it is thicker in the periphery, it is wide, it is more mobile. So because of these reasons, so we have less injured ligamentous lateral meniscus. Okay, so medial is more commonly injured to the percent of 71%. Again, mechanism of injuries, rotational force or a twisting force as usual. So fibrosis, so in young adults or in young athletes, definitely this is the reason, rotational or twisting force. So when it comes to a middle age or an old age, fibrosis or OA changes, grade 4 OA changes, or if there is too much of fibrosis, then also there is decreased amount of mobility of the meniscus. So that can also contribute to the tear of the meniscus. Okay. Apart from this, the other causes can be abnormal meniscus shape. If it is not crescent-like or if it is totally having an abnormal shape, okay, then also it can become a cause for tear. And abnormal stress due to chronic ligament laxity. Earlier, there was a history of old tear. So because of the old tear, now this meniscus has become very lax. So because of this reason also, there can be a tear of the meniscus. So these are the common causes of this meniscus injuries. So what do we see in the clinical features? So there is pain on the inner aspect of the knee. Okay, inner aspect, because medial, we told that medial meniscus is more common. So obviously pain and swelling and tenderness will be more in the inner aspect of the knee. Okay, and there is history of locking. I told no, it looks like it is stuck in between and the person feels as though he cannot come out of it, or he cannot stretch his knee. He cannot extend his knee. He feels that kind of sensation. So that is where we call it as knock knees or locking of the knees. So in 40% of the condition, this is the common thing that we appreciate when there is a medial meniscus injury. Medial joint line tenderness is positive. So from the center, when you palpate the joint line, so the person will not even allow you to touch there. So because of so much of tenderness in that area. Okay. So these are again the video links that I have put for you to see these clinical examinations. It will take a lot of time if I go on doing these things. Slide is not moving. Slide is not moving. You can see the next slides. No, is it?
No, ma'am.
It is not seen, right?
No, ma'am.
I don't know, because of some server issue or what, it's not moving here. So clinical features, this is what you have to know. And again, in this meniscus injuries also, we have, till we get back the slides, I can just tell you like this, because now you have seen the location and you know where it is. So we have again 3 grades in this. So again, initial grade, intermittent grade, and then the last grade. So in the initial phase, patient complains of severe pain. So inside of the knee, there is severe pain. There is locking of the knees. So initially, a little more further, the person periodically gets this locking. Means today he is fine, again after 2 days he feels that locking sensation. Again there is increased amount of pain and swelling day by day. So that is when it is intermittent. So last grade we say when this is too much, when it is too much disabling, where the person cannot do his routine activities and too much of tenderness is there in that area. So we can grade it as the last grade. So in this also, investigation wise, again we have to carry out the radiograph or the x-rays, what we do in these views. So our AP view, lateral view, all these things we can do that. Other than that, again, we can go for the MRI. So though it is expensive, it is very much accurate. It shows you, gives you the accurate results. Other than that, as I told you, we can go for arthroscopy also, again to see the inner aspect and the adjacent structures. If they're damaged, we can actually view through this arthroscopy to identify which meniscus is torn from inside. So for that also we can go with this arthroscopy. So apart from, other than this, we can also have the differential diagnosis for this medial meniscus injury is fracture of the tibial spine, because the tibial spine is in close proximity with the medial meniscus. So sometimes we can also clinically wrongly diagnose that there can be a fracture of the tibial spine also. But the good thing is clinically that even though the things appear clearly, but when we do these investigations, so that is where it helps you to rule out that there is no fracture. If there is no fracture, then it is meniscus tear. If there is fracture of the tibial spine, then there is no meniscus tear. So the other way. So like that, you can exclude the other things. Other than this treatment aspect, when it comes to the treatment aspect, again, same treatment, conservative management in grade 1 and grade 2. And other than that, if there is again the tear, here they tell some word like that, if the thickness or the torn thickness is more than 10 mm, okay, then we have to go for the surgical repair is what they tell. So thickness, if it is too much increased or if it is partial thickness, then we have to go for partial meniscectomy. Meniscectomy is the removal of the meniscus. So partially, if it is torn out, then we have to do the partial meniscectomy. So what we do is meniscectomy is whatever part or how much ever part is torn in that meniscus, we just debride that part and then we sew it together. So that is what we do the repair, and only that much part is resected. So that is where we call it as partial meniscectomy. So this is the gold standard surgical intervention that we do for a meniscal injury or for a meniscal tear. Okay, so there is also something known as radical, means total meniscectomy. So complete removal of that meniscus. But actually, this is not recommended until and unless it is very chronic, until and unless it's very old, fibrosed, etc. things. We should not do this total meniscectomy, because in future days, as the age advances, he will develop arthritis very easily and lot of stiffness will be developed, and he can also go into OA or RA in future days. So as much as possible, we should try to avoid the complete meniscectomy and only go with the partial meniscectomy measures. Other than that, you tell him not to lift the weights. Don't tell him not to lift the weights. Let him do the rise techniques. Okay. And you can give the skin traction. So once you give the skin traction, that will also help in increasing the force. Okay. So traction is very good in this condition because it's a small structure. So traction can really help in this. Okay, so we call it as Buck's skin traction. Okay, just remember the word BUCK''S, Buck's skin traction. So procedure and all is the same. Okay, giving the skin traction. So this will help in maintaining the length of the the shaft or the length of that particular joint there. So these are the measures that we do. In surgeries, if we do the surgery, then we are going to use the arthroscopy and then we are going to repair the meniscus. That we call it as arthroscopic menisci repair. Other than that, we can do the partial meniscectomy, as I told before. Other than that, there is also something known as meniscal transplant or implant. So this we do when these total meniscectomy, when it fails. So even after doing a meniscectomy, again, if there is a new injury, okay, if there is too much of old scarring left over there. So in such cases, we take the menisci from the cadaver. From the cadaver, we take the menisci and we transplant in that region. So that is what we call it as meniscal transplant. So since 15-20 years, this technique has started, but still today it is not done that much. So gold standard, as I told you, is partial meniscectomy, or before that, even a meniscal repair would be better. Okay, so these are the things that you have to know when we are doing the meniscal, handling the meniscus. So with this, we are ending today's topic. So I'm not able to move the slides. Can I reshare once? Can I close this and reshare once so that it would
Okay,
pop up?
ma'am. Okay, ma'am.
Just because still here they have seen the slide. If they can also really see last part, that would be completing the topic.
Okay, ma'am.
It's visible. Slides are visible.
Yes, ma'am.
Okay. So significance of menisci to the knee, partial meniscectomy increases the stress by 50 to 60%. Whereas when we do the total meniscectomy, see it's almost 4 to 5 times of it that it increases the stress. That is why we don't recommend the total meniscectomy. And menisci repair is actually the best one. If not, then partial meniscectomy would be much more better than that. So these are the other routine conditions which we see. So just I'm telling you the names. You will also be familiar with this. So there can be patellar subluxation, okay, where the patella bone can abnormally slide down or get dislocated from its normal anatomical position during any hyperextension activity like that. So we call it as patellar subluxation. So patellar tendonitis. So ligamentum patellae, patellar tendon, which I showed you in the diagram. So if it gets inflamed or swollen, then we call it as tendonitis. So that can also be the common cause. Knee bursitis. I showed you different bursa, isn't it? Suprapatellar, infrapatellar. So if there is an inflammation or a swelling over this bursa, or we call it as knee bursitis. Okay. Other than that, Baker's cyst. So on the popliteal fossa, if you are seeing the collection of abnormal fluid, so then we call it as Baker's cyst. Okay, so that can also give rise to this knee injury condition. So it can also lead to arthritis as such. Other than that, we can see septic arthritis also. So though it is rare, but still once it is there, it is a very life-threatening condition. It will become worse and worse day by day. So these are the other routine knee injury conditions that we commonly come across in our day-to-day practices. So lastly, I have put this slide so that you know what I have shared the links, and I have put this table so that which test, for when you do which clinical test, what is positive. So how much sensitive is the test? This is what is given in this table. So just go through this table once. That will be like a revision for you. This is what I want to tell at last. So any knee injuries at last, okay, so encourage them to teach them the quadriceps strengthening exercises to improve their movement. Knee instability can be corrected by performing this hamstring or quadriceps strengthening exercises so that they come out of that disability. So when they're in grade 1, grade 2, definitely you can go with these strengthening exercises. So post-operatively also, you can help them out by teaching these quadriceps strengthening exercises. So whichever postures I have shown here, very simple things they are, but so there is stretching of quadriceps muscles, there is stretching of hamstring muscles. So when these get stretched, automatically the person will develop good stability. So knee instability will be reduced in that person. Okay. So with this, we are going to end today's session. So if you have any questions, it's open for discussion. Thank you.
Thank you, ma'am. Thank you so much, ma'am, for taking your time to prepare for such an extraordinary, enlightening session, which was incredibly informative. We will now go ahead to the question and answer session. Shall we begin, ma'am?
Yes, ma'am, definitely.
Delegates, please post your questions in the chat box. Delegates can post your questions in the chat box. Delegates can post your question or raise your hands and can ask questions. Ma'am?
Yes?
There is a question. Will quadriceps strengthening exercises be helpful to young athletes as their routine?
As a routine?
As their routine, yes, ma'am.
Yeah, definitely. But it shouldn't be too much also, because they're basically athletes means always they're already into practice sessions. Already they'll be practicing too much. There will be a lot of stretching exercises there. So only as and when it's required in order to avoid the stiffness future, they can go for it. So excessively also it should not be there. Then the muscles would become, the tendons would become lax. So it should be practiced accordingly.
Ma'am, there is a question she want to ask ma'am personally. You can ask him or Sha.
Hello.
Hello.
Good evening.
Yes,
good evening,
very
madam.
good evening.
Thank you so much. Thank you so much for a very informative lecture. I have a patient age 50, female, and she was complaining of joint pain, severe joint pain, left knee pain, and so I did MRI, and it showed patella shows grade 4 chondromalacia along facets. Posterior horn of medial meniscus shows grade 2 signal and joint effusion. CRP levels were and ESR levels were high a little bit, and pain was too much, and she cannot bend the knee or put pressure on that. So, how to proceed, madam? What will be the prognosis and treatment management?
Okay, posterior meniscus tear, what they're given is posterior horn is common. So
Horn
among
of
the
medial
meniscus
meniscus
tears,
shows, yeah, grade 2 signal. I did not understand that.
No, grade 2 is still manageable. How is clinically, how is her this one movements? How are her movements?
The swelling was too much and the movement was difficult. Suddenly, when she tried to bend the knee and it suddenly makes some sound, or she was feeling something is from inside is moving, some loose ends or something, she was describing in that way. Now the condition is much better. She can do it. Strengthening exercise also I showed, but then when she took an opinion from the orthopedic, they were suggesting the arthroscopy.
So this is the first time that happened, is it?
Yes, yes, ma'am.
Cause for that?
I don't know. Degenerative arthritic changes.
Degenerative, yeah.
Degenerative.
Thing is, when they do the arthroscopy, first if they do see through the arthroscopy, first they can confirm whether there is a posterior tear, means on the posterior horn if there is a tear or not. Other than that, to what extent there is degeneration? Is there a fibrosis? Old scars are there over that region. Okay, whether there is stiffness, is she going into RA? So many things can be seen by arthroscopy. Once they do the arthroscopy, they can confirm the diagnosis, as well they can rule out other things also. So if there are multiple things, like posterior horn is very common. So there are so many types of tear in the medial meniscus. Among them, the commonest variety of tear is posterior horn tear. So that also occurs because of this degenerative changes. So if there is improvement by doing this, that's what RICE technique, physiotherapy, quadriceps exercises, and NSAIDs. With this, if she is coming back to her normal, then always they can wait for doing a reconstruction or a repair. but if on taking that she will be fine, again after few months again she lands up with the disability. So recurrently if it is happening, then they have to go for arthroscopic assisted repair or reconstruction as such. So recurrently if it is coming up, is she obese?
Yeah, 10 kilo plus.
That is also another reason. Okay, because even when
and
the exercise, thyroid. So weight reduction also becomes very, very important line of treatment. So only when they do that, aram se they can do the strengthening exercises. Otherwise, that also they cannot do it properly. Okay.
Okay.
So that may be.
And I had one question regarding when doctor suggested they will do arthroscopy. You were saying it will be first diagnostic. So while doing that, they would do a corrective surgery, or they will ask patient to give the choices and then ask their choice. Patients wish.
Before doing arthroscope itself, they would explain you these things, like if it is a very small tear or if it's a very small correction to be made or a repair to be made. So if it is possible through an arthroscopy, then they will do that repair. Okay. So for which if she agrees, then they can go ahead with that, because it's outside diagnostic as well as a therapeutic tool. So they can do that. So with the consent of the patient, they can definitely do that. But definitely, once again, if it is total tear, again, they cannot do only with the arthroscopy. They have to go for reconstruction again. But obviously with the assistance of arthroscopy.
Okay, thank you so much, madam. And the prognosis, the doctor first gave DMRD, disease modifying anti-rheumatic drugs. So the patient did not patient took for 1 month or so, and after that she did not want to, so she came to Ayurveda. So how important is to taper it down, or just continue along with Ayurvedic treatment?
We can try out with this, then we can check how she is responding. But that's what, if it CRP is double or triple than the normal one, then it will definitely be kashta sadhya. Okay. So at least day-to-day activities, if she is able to do, okay, so that is the best line of treatment that we can do. So Janubasti we can do, Upanaha we can do. So if these things, if they're done along with that weight reduction program, if she is doing able to lose her weight, then definitely she can get back to her routine activities. The aim is only if that stiffness has to be reduced, pain and swelling has to be reduced. This should be the aim of the treatment, because other things are not very easy to bring back to normal because of the age factor, and since the cause you said is degenerative.
Correct. Thank you so much, madam. Thank you so much for your guidance. Thanks.
Thank you, ma'am.
Yes, ma'am.
Ma'am, we have another question, ma'am. Ma'am, Ayurvedic treatment for ACL tear.
Yes, it is once again, ma'am. It's asking is easy, but thing is, again, we have to check clinically the patient, as well as we have to see what grade it is. But one thing I can standardly tell this, if it is complete tear, again, we cannot help out. So even though we can give the medicines, we can definitely give the medicines, external applications, etc., these things, but it will be temporarily for that moment. So finally, because in total tear, definitely we cannot promise that they will get back to this like that, because anatomically there is problem. So we have to fix that or correct that problem through surgical intervention itself. So clinically, if there are no much symptoms, and if they're not obese, and if it is in grade 1, grade 2, then we can definitely try out with Ayurvedic medication along with treatment.
Thank you, ma'am. Ma'am, another question. Ma'am, any experience with Janubasti for knee injuries?
Yes, definitely. That's what ACL tear, PCL tear. We have done simple Janubasti with Janu Upanaha. It has that's what in partial tear where repair was required. In such cases, definitely it will give promising results. No doubt about that. Because whatever they have will be pain, what they have swelling, they'll have stiffness. Okay, so when they are presenting with these kind of clinical symptoms, so Upanaha is the one which is going to relieve from these symptoms. So definitely there is a good impact with this simple treatment.
Thank you, ma'am. Thank you very much, ma'am, for patiently answering all the questions. Now, I invite Dr. Anjana P., ma'am, Assistant Professor, Department of Rachna Sharira, Ayurveda College, Coimbatore, to deliver the vote of thanks.
Thank you, Sri Lakshmi. Good evening, one and all. On behalf of Ayurveda College, Coimbatore and Team Diksha, it is my privilege to deliver vote of thanks today. I would like to express my sincere gratitude to Dr. Dipti G. Godbole, ma'am, for sharing her valuable experience in the topic routine knee injuries. Thank you, ma'am, for accepting our invitation and giving such an informative and such a wonderful class, ma'am. It was really, really useful. Thank you so much.
Thank you.
I extend my sincere gratitude to Team Diksha for providing us with a virtual platform. And I sincerely thank all our delegates who have responded so well and participated in this session. We look forward to welcome you again in our further sessions. Thank you, one and all. Thank you.
Thank you so much for giving me the platform to exchange some of my knowledge with you all. So it was a very good exposure even for me also. Thank you so much.
Thank you, ma'am.
Thank you, ma'am. Work for a cause, not for applause. Live your life to express, not to impress. Thank you all for patiently listening and for the valuable time spent. See you all in the next session. To know more about our updates, please do stay connected with our social media platforms. That's all for today. Most interesting session with lot of new information for us to close our eyes with thought-provoking knowledge. Thank you all for joining us. Thank you.
Can I leave the session, ma'am?
Yes, ma'am.
Okay. Thank you.